I'm Eric Schmidt. I do have a degree. I may not look it. And I got a BS in pharmacy from UW-Madison. Took 6 years to get a BS in pharmacy. Anytime that you're getting a BS and it takes you 6 years, that's BS, you know. Then after I graduated 4 years after that, they went and did 6 years and you get a Doctor of Pharmacy, which is another BS thing. So I went back to school and got my Doctor of Pharmacy. So technically I could be a doctor. Don't call me that. I'm also a board certified pharmacotherapy specialist. All that means is I took a day-long test to say that I know my pharmacology. So does that mean you need to listen to me? Take me with a grain of salt. I'm fairly laid back. I like to answer questions more than just sit here and lecture. I'll let you know the 2 lectures I'm going to be talking about today. I will probably lose you, and it's not on purpose, but it kind of is on purpose. You know some of this stuff. So let me give you the science behind it so I can help build for future, okay? And I love the fact that you guys sit way in the back. That's always fun, you know. That's the way I was as a student too. So if I wasn't on camera, I would actually walk back there because that's the type of person I am. I'd be more interactive. But I'm on camera, and I think the cameraman would probably egg me or be quite angered at me. So let's see. Oh, here we go. What I'd like to talk about today, kind of like toxicology, where are you going to find these chemicals in general? Clinical presentation, signs and symptoms, mechanism of toxicology or mechanism of action, whichever you want to call it, and also talk about treatment. This is a long lecture because I talk about toxicology, things that people are using to kill themselves accidentally or on purpose. And then I talk about toxicology, recreational stuff where people are more than likely trying to have fun and possibly kill themselves. Okay? So I will talk about the gamut. Obviously your resources, I don't have to tell you this, you know, but poison control is ideal and can't be, I would say, broadcast enough. They work very hard to keep people from actually coming to the emergency department or even calling you guys. So often, when I say often, that's maybe a bit too much to say, but many times when I'm calling the poison center because I have somebody who has ingested something, they will tell me, oh, they could have handled this at home if the person would have called them. So you can actually save healthcare dollars, stuff like that. So they are trying to do a good job. So they definitely have triage nurses who actually special training. They do to know how to handle this, and then they have toxicologists there or on call. Our first drug. Let's get right to it. Fun, acetaminophen. Is that fun? No. How many people have seen like a Tylenol overdose? Yes. They seem fairly stable when you pick them up probably, right? Right, and it's probably not until several days later, maybe when you have to pick them up and take them to some other facility, that they're really ill, okay? Where can it be found? A lot of places. All right, over-the-counter medications have it. Some of your cough cold stuff has Tylenol in it, so some people are ingesting because they have a cough cold, and they may take too much Tylenol in that regard. Also, prescriptions have it. Even your prescription narcotics, you got your Norco. The FDA has worked pretty hard to get the amount of Tylenol down in some of these combination products because people were dying. So, good thing. Obviously, Percocet will have oxycodone with Tylenol. So some of these are just examples. Your pathway, like an acute ingestion, is greater than 3 grams technically in adults. Really, if you do greater than 6 to 8 grams on average, that's when it's really going to be toxic to the point where we're going to be worried. Okay. In children, it's greater than 200 milligrams per kilo in children. That greater than 3 grams was a recent change by the FDA. It used to be greater than 4 grams, but people would push that 4-gram limit on a daily basis. And if you take 4 grams on a daily basis, you get the same toxicity. Oh boy, that stinks. So they changed it to 3 grams as a max, which is good. That's where you get that chronic ingestion I'm talking about in the last line there. Normal metabolism. So your body will break down acetaminophen and it will form this NAPQI. Who really cares about the name? Problem is your body can't deal with that. What it will do is it needs glutathione to actually handle that compound. You only have so much glutathione in your body, okay? So if you ingest too much acetaminophen, all the enzymes that work up to this point work fine. But you get to this point where you need glutathione and you have only so much. So you'll run out of glutathione. Then what's going to happen? Well, you still have this compound. It will then bound to your liver cell enzymes and or pretty much destroy your liver cells. So that's how the acetaminophen toxicity is really starting to go. Yes, you hurt your liver, but it's really due to a limitation of your glutathione. Immediate post-ingestion, nausea, vomiting, possibly. Malaise, possibly. Asymptomatic, more than likely. You know, people that acutely ingest a bunch, not too symptomatic, okay? And Tylenol overdose comes in 4 stages, okay? So, and it's all really focused on your hepatic injury is really where you're focusing on. It's impacted by duration from ingestion to presentation. So the sooner we can get them help, the better we can make things. The quantity that they ingested. So if I'm annoying when you drop off somebody and I'm like, hey, do you have a bottle? You know, and I have counted out a Sam's Club bottle, you know, the 500 or 1,000. I've counted out what was left. It's not fun, but it's the right thing to do. So even if you got the Sam's Club bottle, yes, I will count it. Okay, it's to know what someone's ingested, sure. Know if they co-ingested stuff, because obviously that may affect how the acetaminophen is working. Also may tell us how taxed is the liver. Okay, other things may harm the liver as well. And any kind of comorbidities, any other diseases the person has. Those are the things that are going to help us. Ethanol users, in other words, people who drink, it's kind of complex and controversial. People who chronically drink alcohol, their enzymes can be somewhat revved to make the toxic metabolite that we talk about that's rate limiting, and they don't tend to have a lot of that glutathione, a lot of reserve. So they can get toxicity faster than your average person. And anybody who just acutely has taken ethanol, believe it or not, they may actually get temporary protection. I'm not saying, boy, they don't drink at all and they've ingested a bunch of Tylenol, have them drink. No, I'm saying your body will preferentially want to treat the ethanol than it would want to break down the acetaminophen. So if it just so happens that they were drinking when they ingested a bunch of Tylenol, may be to their benefit. Not always, but may. Malnutrition is also a component because you decreased glutathione again. So everything is hinged on that glutathione. I keep saying that word. Here are your 4 stages: clinical presentation, preclinical toxic effects we talk about. 30 minutes to 24 hours post-ingestion, really it's not much. Okay, your hepatic function test probably look normal, and rare that you would see anything else. If someone took a lot, like that whole Sam's Club bottle we talked about, if they took all of that, they probably have a big pile of tablets that won't dissolve. First problem. Second problem is they would also get a metabolic acidosis. Now they're really going to be ill. 24 to 48 hours post-ingestion, sometimes that's when these people show up also, because they didn't feel ill after their first ingestion. Now they start to feel ill, okay? Patients that they start to develop some of that hepatic injury. Your signs and symptoms are your right upper quadrant pain, okay? Tenderness. Some of the symptoms from stage 1 may actually improve. But your hepatic function starts, lab tests, they start going up. And when I mean going up, I mean like a rocket, pretty decently. The other thing that you'll see is elevated PT-INR. What does that mean? Is they become more bleedy, more oozy, okay? They're unable to clot because your clotting factors are made by your liver. And if you start seeing that, especially this early, 24 to 48 hours post, that's a decent injection. Okay? I'm guessing that's pretty good. So these are the things that kind of trip me off to, yeah, they've done a bad job on their liver, right? 72 to 96 hours post-ingestion, this is your peak of your hepatotoxicity. You'll probably get your nausea and vomiting returning as your liver is not pretty much acetylating itself. Depends on how severe the toxicity. You could possibly see a metabolic acidosis. You could see them, having coagulation issues. Renal dysfunction, because your liver is a filter. Well, your other filter is kidneys. So if your liver's not filtering, now your kidneys are getting messed up. Okay. Cerebral edema, because ammonia is made constantly by your GI tract, and your liver processes it. Ammonia causes encephalopathy. So now your liver can't even process your own gut flora, ammonia, and your brain can swell. Does this all sound pleasant? No. And we're 96 hours post. So how much time does that give that person to think about, did they really want to die? Quite a bit of time, to a point where maybe they didn't want to. And they have some remorse there, okay? So your hepatic functions are really elevated. Your transaminases are your enzymes. Your bilirubin is looking at liver function. Your transaminases are going to be elevated first, and then your bilirubin is going to be elevated. And at this point, both are going to be skyrocketing. And your transaminases normally should be like in the 20s to 40s, maybe 50 at best. They'll be in the thousands. Okay, so looking at a lot of damage there. Okay, 4 days to a week post-ingestion. Patient that survived generally make a full recovery. I put full in quotation marks because they've obviously lost some hepatic reserves. So that person should not be a chronic drinker. That would probably be a bad move. But your liver is pretty resilient. You can live with about 10% of your liver and be somewhat normal as long as you're liver friendly. Okay? So these people can, if they make it this far without treatment and live, they could probably live a fairly normal life as long as, again, be liver friendly. The other end of this is you don't make it. You can't live without a liver. Okay? So it's that 96-hour mark. When you start getting to that, to 4 days, we kind of get to know you either need a liver transplant or hopefully you make a full recovery. Some of these nomograms that we use to actually find out, is why the other thing will also be annoying to people and go, hey, do you know when they ingested? Because once I know when they ingested, I'm looking at 4 hours post-ingestion. I can put them on this nomogram and once I get a Tylenol level and find out how toxic are they. Okay? So if I get a 4-hour post level that's here, hey, yay, they're not toxic. That's good. If I get one that's probable, I'm going to be treating them. If it's up here, I'm definitely treating them. And that slide way back several slides ago when I talked about if it was 500, that's ginormously up here, right? So that's where you're starting to see like they took a lot of Tylenol, and it's even going to throw off their whole metabolic pathways. Okay. Treatment. So guess what? What does this patient need? Believe it or not, no. What was the limiting factor? I kept saying the same word over and over again. Glutathione. They need glutathione. Can I give them glutathione? I can, but your body would probably digest it, break it down first. Your body will make glutathione from cysteine, which is an amino acid, just an amino acid. There you go, glutathione. You make it from cysteine, amino acid. We'll give them acetylcysteine, okay? Fortunately, cysteine smells like rotten eggs. Yay. And it's most effective if it's given within 8 to 10 hours, okay, post-ingestion. Comes in two forms, comes in an IV and an oral form. The oral is actually preferred. Reason why is everything you eat goes to your liver first. It's called first-pass metabolism, okay? I want to treat the liver. So if I give it orally, it's better. Two things are kind of bad about it. I'm giving something that smells like rotten eggs, and you have to drink it. It doesn't taste like rotten eggs. It just smells like rotten eggs. So getting it past your nose, you're fine. You could drink it. But getting it past your nose of rotten eggs that you're ingesting is not always an easy sell. But it actually is the best. And actually is the very few times that the loading dose orally is less than the loading dose IV. IV dose is almost always less than the oral. This is the few times it's not, because first pass metabolism is going right to the liver. Oral is so much better. Obviously, you can give it with charcoal, so if someone did ingest within that time where you can give charcoal. If you give it prior to the charcoal being given, you still can give the charcoal. Okay. Fun facts, yeah, it smells like rotten eggs, yay. It's also a fun prank to play on coworkers. That rotten egg smells only stays around for a couple hours, but you put it on someone's chair, it's just fun. Anyway, as a person who has a stock of acetylcysteine and nobody else does, it's my fun and not anybody else's. You can improve that not test, but the taste of it by placing it in a cola, any kind of soda, but a cola tends to make it taste a little bit better, so you can get that rotten eggs. Your IV dose would be a load of 150, and you give that over 60 minutes. Immediately, you follow with a second dose, and your second dose is over 4 hours, and then you have a third dose over 16 hours. And really, your IV form, you can actually get somebody out of the hospital or get somebody treated quicker than you can orally. So here you got length of stay. IV is way better because you can treat them faster, but the better approach is oral. So it's a horse apiece. We would treat them until they were level was 0. So we've had people stay in the ICU for like 2-3 days. Even though their liver function is looking good, they still would have a Tylenol level, and we'd still keep treating them. Just because, even though they probably would have been just fine if we stopped treating them. The moment you don't, and they get liver failure, bad on us. So most time it takes like 24, 48 hours of oral treatment, and most time you're pretty much will be at a 0 and things are good. Sometimes the patient's condition changes, and so then you will have to switch it to the IV. So let's say they're able to take that loading dose orally. So it's 140 milligrams per kilo, yay, and this was 150. So let's say they're able to take that and keep it down, yay. But let's say their condition changes. So we have to intubate them or something, or something where we can't give it orally. Okay. Well, then I could switch it to IV, just obviously minus that loading dose. So I could do bag to bag. And I have done that as, because the person's condition changed. Again, the oral is preferred, but you're looking at, like I said, with this oral, it's every 4 hours times 17 doses, which, goes out a couple days there for you. Some say if the liver enzymes are returning to normal, you can discontinue your maintenance doses. Most people wait until like some of those Tylenol levels are 0. So let's say we have this guy who's a college student who was binge drinking at a party. That never happens, right? You never see college students binge drink. ever. No. My 2 times in college, I would never see this or be part of or anything. So early Saturday, he woke up with a headache and was taking Tylenol strength, several tablets at a time to relieve his headache. Then he'd go back to sleep. He woke, took several more Tylenol, and this pattern kind of continued until he ran out of Tylenol. Right? And he thought, hey, that might be a problem, but he went back to sleep. After sleeping about 12 hours, he woke and thought, hey, my headache's feeling better, but I just ingested probably a big bottle of Tylenol. Maybe I should do something about it. Acetaminophen level of 12, AST, ALT were elevated in the hundreds. His bili was just slightly elevated. Your T-bili or your total bilirubin could be right around 1, 1.5 is not really that elevated. But he feels fine. Should we treat this patient? Yes. Yes, we should. Even though it's been an ingestion and it's been greater than like that golden hour, 8 to so many hours, right, since ingestion, you would still treat him because he still has Tylenol level, 1, 2, save whatever liver you can. So even if his Tylenol level might have been 0, I still would probably give him the acetylcysteine because I'm trying to save whatever I can on the liver. Okay? And that is the reason why I would do that. Money's labs, his AST, ALT are in the thousands. His T-bili is 6. What treatment can I offer him now? I would run my course of my acetylcysteine, try to save as much liver as I can. I would then, and what we did do, this is a real case, we called and got him to a place that does transplants. They can do an eval. Did he need a transplant? I don't know. But at least they could do the eval. They could, if he needed one, they could put him on a list. They can handle that. Okay. So, how serious is Tylenol overdose? Usually serious. When you guys see them, they don't seem that sick, and it is treatable if we can get them early enough. When we don't get them early enough, it's a problem. And educating the public how serious Tylenol is, because it's so readily available. Some people don't think it's that serious, If he was a chronic drinker, it would actually exacerbate it more. If he wasn't, which in his case probably wasn't, he was a binge drinker, but if he binge drank every weekend, then he could technically fall into that chronic, where his glutathione storage is less than expected. So technically that could damage him more with ingestion. Let's say he never drank before. Technically the alcohol was slightly protective, but very, slightly. So if he was a good college student and probably drank every weekend like college students tend to, his glutathione stores were probably a little less than would be expected and actually be more harmful. No, it's the metabolite that's really the issue. So it's really the liver function, So could it be removed with dialysis? But it's really the metabolite that's in the liver that's the problem. So it's kind of we're kind of hung on that. So as long as we can supply the liver what it needs early, they can take that Sam's Club bottle and we can handle it, and we get them early enough. Aspirin and salicylates. Okay, where can this be found? You guys know this stuff, right? It's over-the-counter products. Your aspirin, bismuth subsalicylates. Anybody know what that is? It's Pepto-Bismol. That's a lot of Pepto-Bismol to get this much salicylate. So you're drinking like a lot of Pepto-Bismol. Okay. Oil of wintergreen. Believe it or not, you don't need a lot of that oil of wintergreen. It's very high percent, and actually could be dangerous with kids. So that oil, some of these people who like, some of that aromatherapy that smells good, toxic stuff, technically, when you're looking at oil and wintergreen, okay? And your sports cream, and there would be a lot of eating of sports cream. That, I can't even imagine, okay? So let's not pretend on that one. So prescriptions, you can also find aspirin or salicylates. They're not prescribed as often, but certainly can be seen. Acute toxicity. Tachypnea is its hallmark. They are breathing fast. Nausea and vomiting, tachycardia, hyperpyrexia, and tinnitus. What? Tinnitus. What? Tinnitus. Thank you. Yeah, ringing in the ears. Okay? Clinical presentation is in 3 phases over time. Your first phase is a very short phase. Okay? You get tachypnea as a result of, actually it winds up, aspirin and salicylates trigger your breathing center. So you actually start to just breathe fast, which actually causes a respiratory alkalosis. Respiratory alkalosis will then trigger your kidneys to go, oh, I need to get rid of some of this bicarb and stuff. And so your kidneys will dump bicarb and hold on to chloride, which is unfortunate because you'll need that bicarb later. Phase 2, what happens is you increase in metabolic acidosis. And gosh, you would need that bicarb now because you got an acidosis, okay? And when you got an acidosis, what do you wind up doing? You try to breathe it off. So you get tachypnea. So they should be breathing fast when you first see them, no matter where they're at. And that first phase is very short, okay? But the hallmark is they should be breathing fast for you. Children will get a kind of a pure metabolic acidosis, and they just cannot compensate, and they will peter out on you, which is unfortunate. Because the best way is if they're able to keep breathing and you kind of know where their pH is at, because when their body's pH is starting to normalize with your interventions, they will just slow down their breathing. But when you wind up intubating them, they can't do that because you're breathing for them. And so you really got to be more vigilant on where their levels are. Phase 3, you got potassium, bicarb depletions because of everything that is going on with your acidosis, dehydration, non-cardiac pulmonary edema, and you progress to a metabolic acidosis full on. So what is going on? What is going on with aspirin and salicylates? Initially, like I said, you get the hyperventilation, which causes that respiratory alkalosis. It stimulates the respiratory center initially. Your alkalosis compensatory mechanism, your renal function, winds up dumping. And you develop a metabolic acidosis, which is unfortunate because you're going to develop a metabolic acidosis with your poisoning. Really, what does your salicylates and aspirin do? They interfere with aerobic metabolism. You are a 2-fuel system. You're a flex fuel. Well, before cars were flex fuel, you guys were flex fuel, okay? You breathe, okay? You take oxygen and you burn sugar. Yay, okay? And you use your mitochondria to do that. When you outrun that, you switch to anaerobic metabolism, you make lactic acid. Hence why if you're running for long distances, your legs start to hurt. That is lactic acid in your legs going, if you slow down, take a couple breaths, we'll switch to the other fuel. Okay? It's your body telling you that. What happens with this is you uncouple your oxidative phosphorylation so you can't make the energy. And your cells change to anaerobic. So it switches to the other fuel, lactic acid. So you're just going to be becoming acidotic. That's what's going to happen. Anaerobic metabolism, pretty much end product is you get a lactic acid, and your anion gap and all your other electrolytes start to go haywire. As you know from your heart, is your heart really like salts in a specific, way. They like potassium at a certain level, like sodium at a certain level. So when they get all out of whack, your heart's messed up. You're already breathing fast because you're trying to blow this off. So you see where this is going. It's really a overall big mess. If we get them early enough, we can charcoal them. Rarely will we do gastric lavage. These are the rare people. I've gastric lavaged only a few patients in my time. I've been in the emergency department at Waukesha Memorial since like 07 till now, and I've only done gastric lavage like 3-4 times. Okay. The few times, like half of those were probably aspirin. It's worth getting that out and possible aspiration compared to all of this trouble that occurs. Okay, that's how serious it is. I'm like, I'll take aspiration, that's fine. And aspiration is not that good either, right? So what else do we want to do? Fluid resuscitation. So obviously in the field, give them fluids. Electrolyte correction, that'd be tough to do in the field because you don't have labs, Enhanced elimination. If you give sodium bicarbonate, it actually enhances its elimination. It also helps fix some of the acidosis. I want to temper that. We can't just fix the acidosis with the bicarb. Okay? The only way to fix is obviously get rid of the aspirin or salicylate. Your good treatment, though, talked about before, dialysis on this one. So those people that I couldn't gastric lavage because they waited too long and they're symptomatic, we'll put them on dialysis and we can remove it. Okay. Tricyclic Antidepressants. Has anybody ever seen an overdose on this? Yeah, it's not too common, thank goodness, because there's other antidepressants out there now. I always thought it was sad. They got people who are depressed who may possibly kill themselves, and they hand them a drug that will kill them. Is that smart? No. Okay. So we came up with different meds that actually are safer, technically, in an overdose. Amitriptyline, clomipramine, doxepin, imipramine, nortriptyline. Those are some of the ones that you'll probably see. It is prescribed for depression, neuropathic pain, OCD, anxiety, migraine, sometimes just small dose for sleep. You take a small dose at night, you get tired, voila, you sleep, Cardiac-wise, sinus tachycardia and hypotension. It will impair your cardiac conduction. So you get a wide PR, your QRS is wide, and your QTC interval is long. What happens when your QTC gets real long? What happens? Yeah, torsades de poids, if you like the French. Sounds nice, huh? Twisting of the points. Central nervous system-wise, sedation, seizures are a possibility. May rapidly progress to just being near coma state, okay, obtundant. You get an anticholinergic effect, which this actually winds up being your friend, and we'll talk about anticholinergics in the next little bit. Risk associated with the toxicity, seizures, and cardiac arrhythmias. You can actually get something that looks like Brugada syndrome. Brugada syndrome is very rare, but it's that whole PR and all these things that are off. If it was due to just regular illness, we call it Brugada syndrome. I actually had a patient, one of my first patients in the emergency department. I was just doing they were going to cath lab. The rhythm was off. They thought maybe he was having a heart attack, something. And so I was just going, I was figuring out what his meds are. And he was actually prescribed twice the maximum dose of nortriptyline. I was like, just a moment. And I go, hey, he's taking twice. He's the one patient who's compliant in his life, who actually is taking what his doctor told him to, and Dr. Mina goes, hey, let's get some bicarb, let's get some stuff, which will help with treatment. And it started to change his EKG. So you can be prescribed it, which it's only happened once that I've seen. Was an out-of-state person. I kind of felt bad for him. I don't know if doctor didn't like him or something, but whatever. Cardiovascular toxicity is really the whole risk of death, obviously. Inhibition of CNS neurons, so your nortriptyline and your serotonin reuptake. That's what's really causing your sinus tachycardia. Okay. If you get somebody who is out partying and they take ecstasy or they take something like that, right? It's the same stuff. It's nortriptyline and it's also your serotonin. They tend to have a fast rate, right? Yep. So you're going to see the same thing. That's why you're trying to explain the same mechanisms. That's why I tell you the mechanisms. It's boring that I'm telling you the mechanisms, but then you can kind of relate it to things you already know. It will inhibit your central and peripheral muscarinic. Boy, that's a whole new word, huh? Muscarinic. Have you heard that ever before? Yeah, that's a whole new system there. Acetylcholine receptors. Agitation, delirium, hallucinations can be associated. And guess what? When you activate this, you get tachycardia. Woohoo! So that's two things, reasons why the person's fast, okay? You inhibit the peripheral alpha-1 adrenergic receptors, which causes hypotension. If you cause hypotension in somebody, their heart should what? Right. So if someone said, hey, I took a whole bottle of a tricyclic antidepressant 4 hours ago, and their heart rate is 60. Okay. You better have taken a whole bottle of beta blocker too to explain that. They should be fast, right? Inhibition of your CNS GABA receptors will cause seizures. Guess what your lorazepam does? It hits your GABA receptor, okay? You can actually stop seizures. So when you actually block those receptors, it can actually induce seizures. Does that make sense? People that are seizing on you give Ativan, which hits GABA. Yay! So you can stop the seizure. So if you acutely take all that away, you can cause seizures. Inhibition of histamine H1 receptors, you get sedation. So let's say if I give you Benadryl, are you tired? Yes. Makes sense, right? You also get hypotension. Inhibition of cardiac fast sodium channels. Oh, you're way out there now, dude. You're talking about sodium channels in the heart. Stop it. Yeah, sodium channels in the heart. Slowing of phase 1 depolarization resulting in prolongation of your PR, QRS, and your QTC intervals. Guess what? All that tachycardia we talked about before, they tend not to go in. Rarely will they actually go into torsades de pois. That known fact has helped me in another situation. I'll tell you later about, unless you wish to hear it now. I don't want to confuse anybody. People are already looking at me like, you've said a lot of receptors, dude. I'm really, you got my mind blown here. Apologize. The reason I mentioned about the sodium channels, wanted to explain how the heart is being affected. Your sodium channels are one of the first to depolarize, okay? But there's certain meds you should not give to these patients because of that, okay? And if somebody may look like they may go into arrhythmia in the field, you may give something. Okay, we'll go through this and we'll see things that you probably shouldn't give. Obviously, decontamination, we could give charcoal, yay! And this would be one where I wouldn't mind doing gastric lavage, and I have at least once in the past, okay? You got your impaired cardiac conduction, you can give sodium bicarb, or in the field that would probably be of great help. Avoid antiarrhythmic class 1A, 1C, and 3. Class 3 has amiodarone in it. You guys have amiodarone on your rigs. Oh yeah. If someone started going into something ventricular, what would your protocol tell you to do? Said hit them with amiodarone, wouldn't it? Yes, it would. If you know that they've taken tricyclic, pick up the phone, you talk to the doc first. It may be okay still to do it, may not be okay. I want to warn you now, okay? Class 1A in 1C, you don't have, wait, you may have procainamide. That's 1A. If you have procainamide, you cannot give 1A either. Lidocaine is 1B. You could give lidocaine. So there's 2 antiarrhythmics that you may have in your possession that you may wish to give because of what's going on with this patient. Stop. Okay. You give an AMP. You may see in that patient that was technically prescribed, twice the max, we gave like an AMP, and things started to improve. Like, wow. Don't have to necessarily go hog wild. If, just like things improved, okay, I'm happy with that. They start going a little wider, a little funnier. Give some more, Hypotension, fluids, dopamine would be fine if you needed to. Granted, they're tachycardic. Dopamine is not your friend when you're tachycardic, normally. You don't have access to norepi in the field, but I have access to norepi. Norepi may be a little better preferred because I don't get the tachycardia with it, but I can fix your hypotension. Fluids are really your best friend, almost always. Seizures, benzodiazepines are always good, okay, seizure-wise. And especially we just talked about how the drug is working. It actually took away from that GABA. Your benzodiazepines really will help you in this because you're actually helping that GABA calm down. And you really see those seizures stop should, okay? See, this is why I explain all this that's going on with the receptors. I'm explaining you why you're using what you're using. Instead of just telling you, do it. Who cares? I'm telling you why. And now you'll know, hey, I should probably call before I give my amiodarone. Also avoid Dilantin, which is phenytoin, because that technically is a sodium channel, technically. Nothing to do with the brain, everything to do with the heart. Dilantin can be a sodium channel, antiarrhythmic technically. So we got a male, student who took 2,000 milligrams of amitriptyline. What signs and symptoms will you see? Tachycardia. Yeah. Absolutely. Are they really up and wired? No, they're going to be pretty. Okay. That's what you should see. Okay. So what treatments could be used? Let's see, if they're hypotension, fluids be nice. Bicarb, yeah. Maybe, especially if you got some EKG changes that are really kind of funky. You're like, oh, this is not seen this before. That's pretty much what you'll see with these overdoses. You're like, things are just really long and really weird, and they're going fast. So volatile liquids. Where can they be found? Methanol. Methanol is varnish removers, fuels, antifreeze. That's old school. They don't have methanol anymore, technically as antifreezes anymore. But if you got somebody old school, I don't know how old that stuff would have been, man. It should have fallen out of that radiator already, man. I'm saying that thing should have rotted out already. Anyway, and moonshine. So you got anybody making home brews, Remember, your methanol is the first distillant, so normally pour off the first 500 mLs, just saying. Not saying I distill or know anything about it, just saying, okay? Acetone, industrial solvents, paint thinners, nail polish removers, isopropyl or isopropyl alcohol, obviously rubbing alcohol, sanitizers, okay? Ethylene glycol. Wherever you find ethylene glycol, this is in our current antifreezes, okay? Hydraulic brake fluids. Snow globes. Yeah, that's why some of the snow globes have changed. They're like, boy, the snow used to fly around much better in the older ones. Yes, it's because they had something else besides water in them, and then kids would break and possibly drink a sweet liquid. That was ethylene glycol. Oops. So we give away, okay, the snow doesn't fly around as much, but kids aren't getting hurt. And any kind of winterizing solutions. And where can you find ethanol? That is your normal drinking alcohol, and if you're distilling, that would be minus the first distillant, then your ethanol is coming out. Methanol, if some at first signs and symptoms, they look drunk. Okay. Pretty much that's all I have to tell you. Lethargy, possible cerebral edema, pretty much they look drunk. That's what they're going to look like, okay? They look intoxicated. As it progresses, you'll see some ocular changes, okay? Classic signs and symptoms, this is more on our side that we would see this. You get a metabolic acidosis, okay? So they may start breathing fast on you. It tends to be a little bit later in their presentation. And they get increased osmolar gap. And I'll explain that osmolar gap thing in a moment, okay? Acetone, CNS depression, they look drunk again. Hyperglycemia, so the blood sugar should be elevated. Okay. Elevated is way better than not elevated, obviously. You know. You also get ketones, because acetone is a ketone. So they seem like it'll kind of mimic diabetic ketoacidosis, but it's really not a diabetic ketoacidosis. Okay? So they may pee a lot, stuff like this. Okay? Signature exposure may get some tachycardia. Obviously, acetone is not necessarily gut friendly. Okay, so you can get some bleeding, some other stuff going on with that. Some respiratory depression, but that is true with any alcohol. If you drink enough of any alcohol, you will stop breathing. Okay. Isopropyl alcohol will resemble ethanol intoxication. You look drunk. Okay. And ethylene glycol, you look drunk. Later presentation, your kidneys are not happy with you, and you may possibly seize. Of that whole list, the ones that are of dangerous, methanol, ethylene glycol. The other ones, in the long term, not dangerous. Okay. Methanol, early symptoms, you look drunk, you're drowsy, you feel a little bit better, like, ooh, well, I had a good time. And then later on, oh, I can't see. Headache, nausea, and vomiting, visual disturbances. Ethylene glycol comes in 3 stages. You're drunk, CNS depressant, stage 2, mild hypertension or tachycardia. You start getting an acidosis. You can develop severe calcium issues, so you start losing some of your calcium because that's what's happening. Okay, and when your calcium starts to disappear, your muscles use calcium to contract. Okay, they start becoming hyper or hypo. So they may be hyperreflexia, so they may be flexing. You know, so they may get people that are kind of stiff, or if you hit them the wrong way, they're jerking. Okay, and they can get a QTc prolongation because of your calcium. You got calcium channels, right, in your heart? Yeah, you do. So you're affecting the calcium, it's going to affect your heart. Most of the deaths associated are going to happen at this time. If you make it past that, woo, okay, you're probably going to get renal failure. Methanol, why is it toxic? It oxidized by alcohol dehydrogenase to what? Formaldehyde. If I say, hey, let's drink some formaldehyde, you'd be like, what are you? You're nuts. People, when they're ingesting that, are essentially doing the same thing, okay? Yay, we can preserve stuff in formaldehyde, but you're not really preserving your body in formaldehyde, okay? Formaldehyde is oxidized to dehydrogenase to formic acid. Formic acid causes profound metabolic acidosis, which we talked about. Formic acid is also a direct toxic agent to the optic disc and the optic nerve. Oh, that's probably a problem if you wish to see, you know. And your inhibition of your cytochrome oxidase will affect how your sodium-potassium pump works. And again, is that important, your potassium and your sodium levels, just for your heart conduction itself? Yes, right? Acetone, really kind of an unknown mechanism. It's pretty much a direct CNS, depressant. Endogenously, you actually do make some acetone in your own body, so it's not necessarily not great for you either. I'm not saying, hey, let's go slug some acetone. You know, it's going to burn a hole in your stomach as well. But the overall, not so bad. Isopropyl alcohol oxidized by 2-acetone. Oh, not so bad. It's 3 times as potent as regular ethanol, though. So if you get someone who actually does ingest this, you know, even a smaller quantity, they're really drunk. Okay. I've had an accidental ingestion of isopropyl. This lady was at some facility where they had some kind of, you know, wipes, sanitary wipes, on the table. Well, and she took the top off. Thought it was like she had vision issues. Okay, she was older, had vision issues. She took the top off and poured, and maybe it was out of the pole thing, so it was just the water in the bottom. I don't know, but she poured it, you know, and then proceeded to drink, and it's like, boy, this is horrible. Now I got this elderly lady who took a nice mouthful of 3 times as potent as ethanol. So I got this really drunk old lady. Okay, she was wound up being fine, but as you know, you don't need much to actually get there. Okay. Ethylene glycol will oxidize by your alcohol dehydrogenase. Did you see that in the previous one that we were concerned about, methanol? Yes, you saw alcohol dehydrogenase. So it's important because in a moment I'll tell you why it's important. Glycoaldehyde, that is oxidized to aldehyde by aldehyde dehydrogenase to glyoxylic acid and oxalic acid. This is where you get your toxic effects and you get your metabolic acidosis. Can lead to encephalopathy or swelling of the brain. Your renal failure, your kidney failure is caused by tubular damage from that metabolism, and you actually wind up making calcium oxalate crystals inside your kidney. So you get a nice, nice cast form of your kidney. Yay! Just to preserve for future referencing, I guess. People used to bronze shoes. I guess you can have a nice cast of your kidneys if you wish. Hypocalcemia is what's occurring with that oxalic acid, right? And we talked about the dangers of calcium. What's important for me is to find out how toxic somebody is, or someone does ingest this stuff, one that normally not as reliable or not able to answer, okay? So I can calculate a guess what their serum osmolality should be. And even if they have alcohol on board, I can still make a good guess of what their serum osmolality should be. Then we get a measured osmolality. If there's a difference between the two, I have a product in the person that I cannot take account of. So if it's greater than 10, some say maybe 15, if my difference between what I expect and what is measured, there's a good chance that they have ingested one of these. Okay? And I want to treat them then. What do we treat them with? Old school way was ethanol. You just drink up. So if they come in and they're already drunk, woo, that buys me time. Yay, you treated yourself at home. Thank you. How often does this occur where they've ingested one of these poisons and ethanol? Actually, more times than not, which is good for me because they already had that treatment on board. That buys me some time. It's not our current treatment of choice. Okay, there's a different treatment. I'm old enough to actually have made this as an IV form. I'm giving somebody alcohol through the IV. Yes, if you think about that, right? But what you want to do is get them at essentially what would be a 0.1. So get them essentially legally drunk. Well, 0.08 would be legally drunk now, but 0.1 alcohol level. And keep them there until the toxin is not detected anymore. Voila. New drug on the market. Now we really don't do not done that alcohol IV infusions or giving people alcohol for treatment in quite some time. It's fomepizole. This is your preferred treatment. What does it wind up doing? It actually inhibits your alcohol dehydrogenase. Remember we talked about like methanol? Alcohol dehydrogenase made it to formaldehyde. Voila. We're not making formaldehyde now. Your body will get rid of it in a different way. You know? And if we need to, we can always do dialysis if it's so bad to actually remove this stuff. But we're able to inhibit that formation of some of that toxic stuff right away. And we go end up saving people that way. Hypotension. You'll get AV blockade. Okay? You can possibly develop some arrhythmias, but that's with a few of them. Seizures and coma can occur. A few of these do go up into the brain and make the brain slower, and so the person will be either sleepy or in a coma. Propranolol is the most lipophilic. If I say lipophilic in the past or in the future, that just means fat-loving. If something is fat-loving, it can get into the brain easier. So propranolol is lipophilic. It can get in the brain, and you can actually cause someone's brain to slow down or not be as fast. So they may be lethargic and or non-responsive if they took a whole bunch of propranolol. Calcium channel blockers, what do you expect with this? Hypotension, obviously bradycardia, same stuff that you see. AV blockade. Besides the obvious mechanism of toxicity, you kind of know how these things work. I don't want to tell you, hey, this is how they work. You know how they work, okay? Beta blockers also inhibit your G protein response, which will convert your ATP, so your energy levels actually wind up going down. You probably can get somewhat a slight acidosis that can be associated when you do that. Results in less calcium and muscular contraction, so they may be pretty much dead weight for you. Calcium channel blockers, you get slow calcium channels in your beta cells, which will inhibit insulin release, so they can get hyperglycemia, which is actually beneficial when we talk about our treatment. IV fluids, good way to get somebody a bit pressure up if they're hypotension. Okay. Vasoactive agents, meaning something that will speed up their heart. Name something that will speed up someone's heart that you have in your possession. Epi, yes. Atropine technically would not work on this, technically. But if you give something that's going to force, like if you have dopamine, that may work, okay? Epi at its 1 milligram may be too much. May not be. Because they might have a lot on board, and you give them a milligram of epi, and they got faster, but they didn't get like tacky. They got a lot on board, okay? I'm not saying that's a test to do. Obviously, you got to follow your protocols, but it would be, you know, you would expect to still see the tachycardia, okay? Glucagon, it can be a treatment. This is more for us than you. I don't think you carry enough glucagon. I don't think you have 3 to 5 milligram IV bolus. And if you give glucagon IV bolus, and they're somewhat with it, expect vomiting to occur, which is why you really don't want to give it also. But what this will do is actually it affects that mechanism. It increases that cyclic AMP we just talked about, kind of turns the AV, SA and AV node back, okay, and gets that calcium back. Yay. Okay. Often what we do is we will give insulin boluses. And I mean scary insulin boluses. As in, we're confirming for sure you took a lot of beta blocker doses. If I give somebody 1 unit per kilo of insulin, let's say someone weighs 70 kilos, that's 70 units of insulin. Sub-Q is actually a decent dose. We're giving an IV push, okay? If we are wrong, we're going to make them hypoglycemic, and it gets ugly then, as you know from when you pick people up who are hypoglycemic, okay? So you got to be rock solid for sure. But believe it or not, this works like a charm, okay? For the same reason that the glucagon also would work, okay? You actually wind up fixing the calcium. You're fixing the way the intercellular is working, okay? So you can also get calcium boluses. I don't know if you guys carry calcium. Some do, some don't, I'm not sure. But that, especially if someone took a calcium channel blocker, and calcium is what's being depleted, it may buy you that minutes, okay, to get somebody to the hospital, if you have that at your disposal. Anticholinergics and antihistamines. Where can you find these? Well, you can find them prescription-wise. There are anticholinergics. Boy, there's a long list of them. Antihistamines, so that'd be your Benadryl, okay, hydroxyzine, stuff like that. In higher doses will give you an anticholinergic effect. Antipsychotics will give you an anticholinergic effect. Mostly the older ones, haloperidol or Haldol would do that, okay, in higher doses. Tricyclic antidepressants, we just talked about. Tricyclic antidepressants. They can, and carbamazepine, which is actually a seizure medication. Or counter products, mainly your antihistamines are your ones that you're going to see, okay. Some plant extracts can also, or plants. So you get a kid chewing on a plant at home. Can do this. Signs and symptoms. Red as a beet. You get flushed. Okay. Dry as a bone. They can't pee. They can't spit if they wanted to. Okay. No need for a spit mask. They couldn't if they wanted to. Blind as a bat. Big pupils. Mad as a hatter. Altered mental. I mean, great. They seem. Yeah, they're out there, you know. Hot as a hare. They tend to be pretty feverish or hot to the feel, okay? And they forgot in their whole little mnemonic tachycardia, because that's what you'll see, tachycardia, okay? So when you see this, it's these it's the anticholinergic. Antihistamines in normal doses won't give you this. In an overdose, they will. Mechanism of toxicity is pretty much an extension of the pharmacologic effects. It's going to antagonize your muscarinic, which is your acetylcholine receptor sites. So in the brain, all those will be either activated, your thalamus and your hippocampus, which is why they're altered, okay? Parasympathetic nervous system, sweat glands kind of shut down. Micturition reflex, which is your reflex to tell you, I got to take a pee. That goes away. So they can build up a whole lot of urine, technically, and they don't get that, oh, I got to pee. So they'll hold on to urine for a while, okay? Symptomatic treatment in this is a mainstay. Pretty much give them fluids, keep them from hurting themselves because they're nuts, get their fever down, let the toxin pass, more than likely they'll be fine, okay? Anybody ever pick up somebody who has done some of those Coricidin HBP? Yeah, I think almost everybody has. It just seems like, from my mind, I'm sorry, or at least where I work, I see it more than I'd like to. They tend to be nutty, right? Like a somnolent and then nutty. Well, that's true, because dextromethorphan in an overdose will do that. But often, it's that antihistamine that's in there as well that causes this anticholinergic effect. So they're nutty on top of a dextromethorphan overdose will cause people to be nutty. So now you got somebody who is ragingly crazy. Yes, exactly. And they tend to be fast. The dextromethorphan is not causing that tachycardia. It's actually the antihistamine more likely causing that. Okay. Cyanide. Where are you going to find cyanide? Electroplating. Okay. Stainless steel manufacturing, smoke inhalation during an enclosed space fire. So you guys should all be aware, if you're firefighters, to know of cyanide poisoning. If somebody has the black around their mouth, there's a chance they've had cyanide poisoning, right? Terrorism, this would be hard to actually do as a terrorist. Cyanide irreversibly binds to your mitochondrial cytochrome oxidase, so you cannot use your respiratory fuel. You have to switch to anaerobic metabolism. And you wind up making lactic acid. And it's permanent kind of thing. You can't knock that cyanide off. So this is ingenious. I wish I would have thought of this. But it's ingenious. That's why I didn't think of it. The treatment for this is hydroxycobalamin. We have it. It's called Cyanokit. You give 5 grams of hydroxycobalamin. If cyanide is present in the body, you're going to make hydroxycobalamin into cyanocobalamin. Cyanocobalamin is vitamin B12. Yay, B12. You'll pee it out, and it's good for you. Hydroxycobalamin is actually a form of B12 in itself. So giving somebody 5 grams of B12, the risk is low that, oh, if I'm treating somebody, because I don't know what their cyanide level is yet, but boy, they got a lot of soot around their mouth and things don't look so good, I'm probably not causing harm by giving them a dose, okay? Old school, we used to have sodium nitrate, sodium thiosulfate, and amyl nitrate. This is the old Lilly kits. They don't actually make these anymore. Nitrates really should be avoided if smoke inhalation is kind of the cause, because you can actually do a little bit more damage than good, which is kind of silly because, at least where I'm at, I don't see a lot of electroplating. I haven't seen a lot of terrorists, for cyanide poisoning. More than likely, I'm going to see it by smoke inhalation. Well, I can't even use this kid, okay? If I had to give it a shot, I certainly would try still to give them. There is sodium thiosulfate that is available, so the Lilly kit is no longer available. So let's say I had like a whole apartment complex and I had several patients coming in. I only have so much Cyanokit. And I'm not going to auction it off. Although I'd like to, but I'm not going to auction it off, okay? So I got to come up with other treatments. I certainly would try if I couldn't get a hold of any more Cyanokits. It's going to possibly help still. All right. So this next section, please, it's not a how-to. I'm not telling you how to you do drugs of abuse. So it's more of a educate you so you can recognize and be able to treat. Some of the stuff is, it evolves so fast that what I give you today, in a few weeks, they're already beyond it, So, give you what I can. First of all, drug screening test, more likely what we do at the hospital. We can test for amphetamines, barbiturates, benzodiazepines, cocaine, marijuana. Oxycodone is separate from your opiates, and tricyclic antidepressants. That's pretty much it. And salicylates as well. But, for you looking for, some of your drugs of abuse and stuff, you don't really test for many of things that come in. So we'll normally be able to confirm, not really. And some of these tests, you can get false positives on and or false negatives. So these tests pretty much just kind of help kind of confirm, oh, this is what I thought it was, okay. And half the time, or more than half the time, I can get that test and it's like, I didn't trip what I thought it was, or what I think it is. It's not going to trip any of these. So we're behind the times in our immediate testing. Can we test for a lot of these other things? Yes, it's a send-out lab. It takes days. If someone is getting a legal draw, they certainly can test for a lot of these things. But up front, for treating somebody, I can't quickly get that tested and find out. So it's all pretty much by symptoms. Simplified approach for drugs of abuse that people overdose on and that you may see. Okay? 2 things. If I get down to 2, that's pretty good, right? So why are people using it? They want to minimize reality, or they love reality so much they want more. Okay? That's really what it winds up being. If you want to minimize reality, opiates, anti-anxiety, insomnia, seizure medications, aka benzodiazepines, alcohol, inhalants, and THC or cannabinoids would be a way to minimize reality for you a little bit. Prescription opiates, codeine, fentanyl, hydrocodone, hydromorphone, Propoxyphene doesn't exist anymore, but it's on the list, just in case somebody has a roll bottle out there, or Darvocet or Darvon. But they stopped making that. I was giving this talk to elementary school parents, and I had it split up like this. So I'm like, so if you have these in your medicine cabinet, right, and if your kid's like that, they're also going to like this. I wasn't invited back to give a talk again to that elementary school parents, but it's a hard fact. So if you got stuff like this in your medicine cabinet and you are not using it, there are certain times of the year, Waukesha County and other counties will have a disposal. Dispose of them. Okay? A little aside, when you see that aside, that's a theatrical thing. Anybody a thespian? Anybody thespian? I was once, could you tell? Okay. An aside is when the actor breaks the scene and talks to the audience. So an aside, heroin as a chemical compound has a lipophilic end. Remember I said lipophilia helps get in the brain, right? Yay! So heroin can get in the brain quickly. It has one end to help it get in the brain. That's good. Well, good and bad. Could get in the brain quick. Technically, if that lipophilic end stayed on, it would get out of the brain fast. And so most of the time, that's what happens. It does stay in that. It does stay on. It will come off fast. That's why heroin overdoses tend not to be hours and hours and hours. Okay, tend to be somewhat short-lived overdoses. The downside is that a certain small portion of heroin has a lipophilic end cleaved off inside the brain area. It can't come out. So a 1 or 2 time exposure to heroin could have somebody physically addicted to heroin. It takes a long time to get physically addicted normally to a drug. Your oxycodone, OxyContin, it would take several weeks, months of chronic use to have your brain go, I like this. Okay? But you have, with heroin, the chance of having a low grade that can't really leave the brain area, just sitting there, loosely hitting the receptor, to a point where your body goes, and then when it finally disappears, your body's like, I need to have something. Why would anybody even want to play with this if after a few encounters you could become physically addicted to it? Makes no sense to me. I know I'm preaching to the wrong crowd. But if I get the word out, you get the word out, eventually someone will go, hey, this is probably not a good idea, especially in this county. Opiates are prescribed. Why are they prescribed? They're prescribed for pain relief. They're very good at pain relief. And people have pain. And yes, if I had a lot of pain, I would want some relief. So good. They're good. They kind of get a bad rap because people overdose on them, people abuse them. Okay. Also, antitussive, which means quiet your cough. You got an annoying cough and you can't sleep. It's nice if you can sleep. Even if it's 4 hours, it's like, oh, right? Yes, it is. So how do they work? It binds to the opiate receptor, the mu receptor in the CNS, and inhibits the ascending pain pathway or the ascending annoying cough reflex to help you to stop. Okay. It alters that perception of pain, so you're not feeling it as much. Yay, that's good, right? It is also will depress your CNS system, so you're not as awake. Hence why you shouldn't be driving while on some of these medications. You're not as awake or as responsive as you should be. Signs and symptoms of overdose. You've seen this. I don't think I need to go through this. Hypotension, weak, sedated. How do the pupils look? They're tiny. Okay. And slow respirations or no respirations, which would also technically be slow, I guess you can say. Decreased respiratory response, you also get decreased oxygen. Monitor your end-tidal CO2 if that's ginormous in comparison to what you would consider normal. That's your first sign someone's going to stop breathing on you if your CO2 is in the 60s. Okay. So when I get a patient like this that's still somewhat breathing, I put them on an end-tidal, find out, they probably either need some sort of reversal or need to be intubated. Obviously, decrease in blood pressure. Other medications, they are not always by themselves. Okay, they're not just opiates by themselves. They can be found with Tylenol, which we already talked about the dangers of. Okay, yeah, you can stop breathing and liver failure. It's a twofer. It's a BOGO. You know, it's great, right? Or it can be with aspirin at times, or ibuprofen. Okay. Altered mental status, may not know what you're doing, and that's why we're talking about driving and/or people not realizing what they're doing in the back of your ambulance. If they are not breathing well, can you breathe for them, please? We're quick going, hey, let's get some Narcan. That's good, but you know what else is good? Oxygen and just breathing for them. Buys you some time. Could buy you the time all the way to the hospital if you had to. Granted, that's a lot of work, though. I'm not saying it's easy. But you certainly can give naloxone, also known as Narcan. IV is preferred if you can. Onset's within 1 to 2 minutes. If your dose that you chose did not work and you're still in the same predicament, you can, depending on your protocols, but I'll tell you, you can repeat a dose and repeat a dose and repeat a dose. If you repeat a dose like as much as you want, and you get absolutely, let's say you get up to 6 milligrams or something like that point, may not be an opiate because you've probably reversed a lot of opiate if that was the case, okay? If you get absolutely no response at that point, yeah, probably not an opiate. Not sure what it is because they got pinpoint pupils. It should be an opiate, but probably not. And I'm not recommending you go up to 6. You follow your protocols. I'm just saying if you give 2, doesn't work, or you get slight response, give another one. Be careful, though, because you can cause somebody to go into withdrawal symptoms. Now you have a nice ambulance ride become not so nice ambulance ride as they are swinging and vomiting at the same time and angered at you. Nothing better than someone angry, vomiting, and swinging at you, right? In the back of a vehicle that's bouncing down the road. Not too good. You can give it IM. IM is slower. It'd probably be the least preferred way. If you can atomize it, that's not bad. You can also, if they are still breathing at, like, say, like 6 or something, you can nebulize it. If they are not breathing at all, don't nebulize it. It's not getting in. You certainly can nebulize it if they're still breathing. Believe it or not, that's a better way, a little gentler way. If they're still breathing and their blood pressure is okay, they will slowly get the reversal. They tend not to get combative. They tend not to throw up on you. And when they get awake enough, they'll just probably flick it off their face. Okay, they're awake enough to swing at it and breathe better. Okay, now, whatever your protocols have to say, but nebulize is not bad. If someone is blue, nope, you're giving it IV or atomize it. Okay, IV would be definitely preferred. How many people have given Narcan or naloxone? Isn't it like almost everybody here? Yes, probably. Our treatment, if someone came in, hey, if they ingested it and it's a long-acting, not heroin, if it's a long-acting, like those prescription stuff can be, I'll give them charcoal if it's within the hour or so, if they're awake enough that I can get them to ingest it without aspirating. Sometimes they're not awake enough, and I can't. Aspiration with charcoal is probably bad. A black lung would probably be bad. I'm pretty sure lawyers would have questions for me. Okay. If they took a long-acting opiate and the Narcan or naloxone worked, Narcan or naloxone will only work for 20 minutes, give or take. Only a few minutes, but 20 minutes, okay? So you may find me annoying going, hey, when did you last give a dose? The reason why I want to know when you last gave a dose is so I can watch and see about 20 minutes or so after you gave that if they're starting to become sleepy again, because then I probably got a long-acting opiate. Because you never really know what they took, unless, of course, they had the bottle right by them. You know, the needle's hanging out of an arm. I mean, those are kind of obvious. Okay, we think we know what they took. Good. There are other times you really don't know. And people that overdose on this stuff are less than truthful. most of the time. I don't think I'm shocking people by saying that, right? Exactly. Less than truthful most of the time. So if that's the case, I can figure out a naloxone infusion by figuring out whatever it took to wake them up. So whatever you gave them that woke them up and then they became sleepy, I might take that into account to what I give them to wake them up and figure out roughly what they need per hour. Okay? Go through how many 3 or 4 half-lives of that agent if we are actually able to find out what it is, and we could turn off that drip and voila, it'll be okay. Sorry for the title, anti-anxiety, insomnia, seizure. I just didn't want to say benzodiazepines, so I have to say what they essentially do. But it's benzodiazepines. Anything LAM, PAMs pretty much are your benzodiazepines, right? So you got midazolam maybe, or lorazepam, or diazepam possibly at your disposal, right? You can use it for seizures. Some people use it to minimize reality. They'll abuse it to minimize reality, okay? That's what they're using it for. Barbiturates can also be used for the exact same thing, anxiety, insomnia, seizures, and can be abused for the same purpose to minimize reality. You do not see a lot of barbiturate abuse. I have yet to see it, really. So the benzodiazepines have really outdone the barbiturates in prescribing and also abuse. Yay. So what is it legally prescribed for? What the title said, you know? Anxiety, seizures, all that stuff, right? Also be prescribed for psychosis, alcohol detoxification, because it hits the exact same receptor that alcohol hits, okay? How does it work? It binds to the GABA receptor, benzodiazepines do, and inhibit that. It causes to enhance that inhibitory effect, so that your brain is less active with it when you're enhancing your GABA. Barbiturates do the same with the GABA. Overall, you get a decreased excitability of the brain. That's why people want it. They want less reality when they're taking it or abusing it. Patients will be weak, sedated, amnesia, specifically more so with benzodiazepines, nystagmus, horizontal, okay? There's only 3 drugs that actually cause vertical, and I'll tell you that in a little bit. Slow respirations, pupils are varied, not necessarily pinpoint, more than likely not at all pinpoint. They could be wide, they could be normal, just sluggish, okay? Dangers, they don't breathe on you is pretty much the dangers. Also can be a daybreak drug, that is also a danger. So if you got somebody who was poisoned, not on their own, be mindful of possible evidence, not that you, but to possibly either point out to an officer or to bring in, whatever. We just want to make sure you're mindful of that, okay? Treatment. If they are not breathing, please breathe for them. It's not rocket science. If they come in immediately after ingestion, we will give them charcoal. You can reverse benzodiazepines with flumazenil, but you won't do this pretty much ever, unless, of course, you know this patient has never used benzodiazepines on a regular basis before. And when you pick up a patient, do you know 100% for sure that they've never ever chronically used benzodiazepines? No. So are you going to be using flumazenil or romazicon? Probably no. What happens if you do that? We talked about the stripping away the GABA, you know, you get the excitability, you'll get seizures. Now you got a seizing patient. What are you going to be giving them? Benzodiazepines. Have you ever been stuck in one of those turnarounds? Oop, I missed my exit. Oop. Yeah, you can avoid that whole loop because you just don't give this drug, right? Seems like it would be the obvious. Hey, they're not breathing. Give them some romazicon. No. Just give them a little bit. No. Don't do it. Ethanol. We talked about the other alcohols. Might as well talk about ethanol. Enhance your GABA receptor just like your benzodiazepine and your barbitals. Guess what? If you acutely take away alcohol from somebody who's chronically been on it, guess what they do to you? They may seize. People that go through DTs can seize. DTs are actually can be life-threatening in comparison to opiate withdrawal. Opiate withdrawal is just uncomfortable. You'll live through it. Alcohol withdrawal, there's a chance you won't live through this, okay? But the same principle that we talked about the romazicon, same principle with alcohol. If you take away alcohol, that's why they feel they have to drink. They have to drink. Their body's going, you better do it, otherwise I'm going to be shaken and I'm going to start seizing, okay? So it's very strong physical addiction. So to be physically addicted is really what you're looking for, to have that GABA receptor to be exposed to it so much that once it's gone, it's extra sensitive. So, and it's variable. To say someone, drinks on weekends, the likelihood is less. Is it possible? Yeah. I mean, the possibilities are, likelihood, So hopefully I answered it. Unfortunately, it's a person-dependent thing. So get back to ethanol. Your GABA receptor, as we talked about, it relaxes. So ethanol causes a decreased nerve excitability. Actually decreases your NMDA receptor. And I throw all these receptors at you. Again, it's not to make your life hellish and throw out numbers or letters, but they're going to come up later. Okay. So you can link some of these things. Okay. Your NMDA is an excitability. So your GABA is like, ooh, relax. NMDA is like, get excited, okay? So alcohol makes you relax, but it also decreases your excitability, so you're really relaxed. You're feeling good, in comparison. So overall, it's a good central nervous system depressant. Pharmacokinetics, small percentage is in the stomach, bigger percentage in the small intestine. I only tell you this stuff to point out my main objection for all this is to show you the new trend. When I mean new, wasn't that way when I was, younger. Now I'm getting older. I apologize. You wouldn't bong anything. You just drink. Why would you take a large quantity? Who cares? You just drink until this mechanism stops. Then you stop drinking. All right? But people are bonging things now. How dangerous is this? Let me show you. So this is my main emphasis on showing you all this kinetic stuff. You're like, so keeping your inks there. Your small intestine, okay, is where most of it's absorbed, and it's first order kinetics. I will tell you that in a moment what that means. Metabolism, this means you eliminate it. It's variable, not really. Metabolism is at a set rate. At zero order kinetics means it's a set rate no matter what. Okay. Distribution is variable based on someone's weight. Okay. Distribution, we kind of look at, in general, just look at if everybody's a cup, and I had to fill them up with enough ethanol, okay? There's variable size cups, right? Certainly are. And it also varies with age and gender. So your distribution is really what's variable. What you can tolerate for alcohol is where how much you can pack away in your body, right? Absorption first order, what does that mean? The proportion or concentration of alcohol, the higher the percentage, the faster you absorb it. Doesn't affect how high it goes, just affects how fast. So if I give you a glass of beer and a shot of whiskey, which will get you drunk? Everybody thinks whiskey. They both will get you to the same spot. Whiskey gets you there faster. The alcohol content in beer is going to be somewhere like 12%, maybe. Alcohol content in whiskey will be 40%, aka 80 proof. So that higher percentage, faster you absorb it, but you will get to the same because the volume is going to be the same. The volume as a shot is like 30 mL-ish. Glass of beer, much more volume, technically the same amount of alcohol. Okay. Metabolism, zero order means it's independent of concentration present. So if you're at a 0.4 and laid out flat, You'll metabolize it the same rate as if you're at a 0.1. Coming down at the same rate, doesn't matter. Binge drinking, or as we would talk about bonging, this is what occurs is you drink large quantities, okay? Anytime you get a volume above 180 mLs, okay, which winds up being like a good 8-ounce glass of water, okay, your stomach wishes to process that. It will hold on to it. So if they're bonging less than an 8-ounce glass of water, yeah, right, okay? They're bonging larger than that. So their stomach will hold on to it. And then it will splurge it into the small intestine where most of it's absorbed. So they may go through the bonging line a couple times, feeling great. And then it gets to the small intestine where most of the alcohols are going to be absorbed. Oops. So your end result is going to be you have now outdrank your metabolism rate, which will then probably lead to you having a decreased respiratory rate, okay? And you might actually have to intubate some people because of ethanol, okay? Most of the time, once you can't actually lift your arm up to your mouth to drink, you would still be breathing, you just are passed out. Most of the time you would still breathe with that. But when you actually do these large quantities, or a lot, you can actually get to a point where you will have to intubate somebody. Don't forget, alcohol is a date rape drug, probably the first date rape drug. And there are normally co-ingestions if somebody was trying to harm themselves or even to have fun at a party. So if you're picking up somebody who is so bad you might have to intubate them, look around, make sure there's not other stuff around as well. Okay. Dangers in children, more so, alcohol burns really quick. Like if I had a cube of sugar and I set it on fire, it would slowly burn. If I had like a little bit of alcohol and set it on fire, it's like nice flash, right? Well, the same thing is with your body. Okay, you burn it really fast, and if you don't have the reserve or the liver capacity to make sugar fairly quickly for your body to use, you'll get hypoglycemic. Kids are at danger of hypoglycemia if they have accidentally got a hold of some alcohol. I've seen children accidentally get a hold of alcohol. Parents were planning a party, made a nice pitcher of some sort of mixed drinks, fruity flavor stuff, and kids thought it was fruity flavor stuff, and they're fairly intoxicated. Well, I'm watching their blood sugar, stuff like that. So if you pick up a child who may have had ingestion of ethanol, just check the blood sugar, okay? You've seen people who are drunk. They should all look about the same. They have larger pupils, and your nose will not lie. If they smell like alcohol, or as we talked, if they smell like scope or mouthwash, same thing, it's going to be alcohol more than likely, ethanol. Decrease respiratory response, please. Breathe for them if you need to intubate the person. Charcoal, I've never seen somebody who drank and showed up within an hour. Never seen someone try to drink themselves to death, okay, where I had to give them charcoal. But if they did, I could possibly give them charcoal. Never been able to do it. I just have to tell people, well, you can always give charcoal. Forget it. Inhalants. Good way to decrease reality. Stay with me, people. Keep awake. It's okay. What are you going to get with inhalants? By the way, these chemicals are in a gaseous state, okay? Glues, paints, paint thinners, petroleum products, gourmet whipping propellants. I've seen that as well. Gourmet whipping propellant is nitrous oxide, okay? Laughing gas. It's a depressant, but it's also a euphoric. So when they're like going out, they feel, ooh, I feel really good about myself, which doesn't necessarily make sense to me. You feel good about yourself, you're sleeping. When you wake, you may not remember you felt good about yourself, but okay. Similar to alcohol in their appearance, may seem drunk and stuff, but really intense, very intense. Okay, it's a quick on, it tends to be a quick off. Again, they appear drunk and cognitive symptom-wise, you really can't concentrate. what happens physically, it affects the nerve transmissions and also alters your oxygen delivery, okay? Fast onset, you could quickly get overpowered by this stuff and pass out, okay? And you could cause permanent brain damage or nerve damage. Well, that sounds good, doesn't it? And it can be addictive. The problem people have is there's gas laws or thermodynamic laws called entropy. If we release a gas, it will go to fill up the whole container. So if I release some nitrous oxide here, it will fill up the whole room. Well, that sucks. I wanted it here, right? So we have to somehow overcome entropy. Most elect to overcome entropy by making a smaller container over their head. Correct? It makes sense. Let's put something over my head to make it smaller. So you can see how this, I understand why you're doing this, okay? So you're going to create a confined space, right? We need a container to get a better high, okay? I get a better high, I can be quickly overpowered and pass out with possibly a plastic bag over my head. Any problems possibly seen with this? Yes. Yes. It's like, okay, I understand why you're doing this, but if I went to you and said, okay, I'm going to give you something, you may pass out and you're going to have a bag on your head. The person would be like, well, that sounds stupid. Why would I do that? But you can understand the reasoning when I go through it. But when you actually take a step back and look and go, no, that's stupid. Yes, it is stupid. And again, love to explain this to people, you know. But treatment, it varies. Often it's a quick on, it's also a quick off. So they get overpowered, they pass out. You know, as long as they didn't pass out with the stuff right in their face, they probably will come to as long as they don't have as long as they don't suffocate. You know, they may need no treatment at all. Hence why you may not see these patients at all. They also may have chemical burns, like inhaled possible chemical burns. They should possibly have a lot of mucus or a lot of runny nose, stuff like that, because they had an irritant that they were breathing in. Okay, you give somebody like that oxygen, they tend to perk up really great. Okay, obviously as long as they haven't suffocated themselves, they can perk up really good. You know, when they're blue, they're not too perky. You know. Sources, we're talking about THC or cannabinoids. Marijuana is your synthetic THC, also known as spice, or K2, if you wish. Pharmacology, I'll talk about that in a moment. It's rarely life-threatening, but people can overdose on this stuff. Marijuana tends to, your overdose of marijuana tends to more from an oral consumption, because you can take orally THC. If you are smoking it, it's harder to overdose because your coordination and stuff becomes not so good. And so if you're not coordinated enough to actually light something, you would probably you're done. You know, so therefore unable to smoke more. But you can actually eat enough that you get to a point where you are overdosing. Signs and symptoms can be bradycardia, hypotension, hallucinations, possibly vomiting from marijuana. More of the hallucinations and hypotension. Synthetic THC, it comes as a stock 97% pure solution that they spray on whatever that can be smoked, ingested, whatever. Okay, it's a concentrated solution. Pharmacologically speaking, it is actually designed, or say, to have someone overdose. Okay, most people are looking for that THC delta 9 receptor agonist. They want that good feeling that they get from marijuana. Okay, K2 spice really doesn't hit that much, and so people will go, oh, maybe I need more. Oh, maybe I need more. Maybe I need more. So you actually see overdoses of K2 and spice way more than you see overdoses of marijuana. People are looking for that receptor, which begs the question, why are you getting the spice or K2 when you're looking for something? Just get the marijuana, call it a day. Again, I should do a how-to to these people too. The other reason it's also geared for overdose, it's 10 times as potent. So a little bit will push you over that edge where you're overdosed. Right? So it really is kind of geared for that overdose. What you see with that, hallucination, agitation, and vomiting, which is like the 180 of what you normally would expect for someone who has just done some marijuana. Normally they're pretty chilled, will eat anything, and not vomiting. I mean, that's why some cancer patients actually use marijuana is to stop the vomiting. You actually get a 180 when you get an overdose of it. You're vomiting, you're agitated. Treatments is pretty much just whatever the symptoms are. If they're nauseated, treat that. The SPICE or K2 is about a 6-hour duration on that overdose. Okay, so if you pick them up early in the overdose, or if you pick them up a little bit later, it's about a 6-hour duration. So, okay, let's switch gears now. No more minimizing reality. Hey, you love reality and you want more. Gosh darn it. I've been shortened. I want more reality. Okay. Amphetamines or amphetamine-like. Also, methamphetamine or crystal meth could be in there. Cocaine, some of your psychedelic drugs are actually in this, where you intensify reality so much you intensified it that it is actually now morphed. And the mechanism of actions are actually using the same. Okay. LSD, PCP, also named just ketamine, phenylalamines. We'll talk about some of those in a little bit, because those are the newer stuff. That's the stuff that keeps expanding. That's the stuff that keeps changing. Okay? That's the stuff that's hard to keep up on. LSD has been around for a while. PCP has been around for a while. Ketamine has been around for a long time. All those have been stable, the same. Okay? All that new stuff is in that phenylalamine. And I'll talk about that in a little bit. The other thing that's in there is dextromethorphan, DM, which is what when they're overdosing on Corsine and HPP, they're looking for the DM. So your cough suppressant is a psychedelic drug. Okay, amphetamine prescriptions. You got Dexedrine, there's Adderall. These are your amphetamine. There's amphetamine-like, which is methylphenidate, also known as Ritalin. A little aside, you can test for amphetamines in drug screen, right? So you should be able to see some of these. Except for methamphetamine is not an amphetamine, it's amphetamine-like. They may not test or probably won't test positive for amphetamines. Okay, so just because they really look like they were jacked up on something like amphetamines. Yes, it could have been. Just could have been like Ritalin or something like that. Wave, legally prescribed for. Oh wait, let me go back. Yes, there is a prescription methamphetamine. And gosh, I got to be hard for a doctor to probably prescribe, I'm thinking. You got a kid with ADD. Hey, let's put on some methamphetamine. I just had to throw that out there. It was or is still legally available. And it really is only geared for attention deficit disorder. So legally prescribed for attention deficit disorder, ADHD, also narcolepsy itself, or narcolepsy in the fact that the disease itself, also patients who have any kind of brain injury may have narcolepsy. So anybody who's had head trauma or cancer, and if it was removed, there's a chance they may have narcolepsy and may need awake meds. So just because you see somebody on these, everybody jumps to ADD, doesn't always mean that's the case. They just may fall asleep, okay? Like you guys in my lecture right now, okay? Stimulant will help you focus or finish the job. That's what amphetamines do. Like you focus. I mean, like you almost hyper-focus, It stimulates your wake center of the brain. It uses the catecholamiine, the fight or flight, okay? So if I release a tiger in the room or a lion, your heart's racing. You're way more vigilant. Throw your neighbor at it, whatever. You're able to do some superhuman things, right? You're able to run better. You're breathing better, all that stuff, right? You also feel better about yourself. You take me to somebody who's like, I'm so depressed. Put them in a room and release a tiger, they get up and run. It's not like, oh, please eat me. No, everybody gets up and run. It's that fight or flight. So you actually feel good about yourself, right? Why would someone abuse these medications? Hey, if you need to stay awake, you get an all-nighter, you need to study for something, you can easily see it abused that way. You get a loss of appetite because when you're running from the lion, you don't go, hey, I need to eat something. No, you pretty much don't wish to be eaten, you just run, right? So you actually don't care to eat. Okay? This is not a sales pitch. I'm like, hey, you're making more weight, you do more work, you're not eating. This is not a sales pitch. I'm not telling you to do this. Full of energy, able to go beyond your normal means, and you feel better about yourself. Cardiac-wise, tachycardia, can get arrhythmias with this. Hypertension. Okay? So some people can stroke out on you, can have heart attacks. Central nervous system-wise, aggressive, anxiety, hyperreflexia, like aggressive as in like swinging at you kind of stuff. And if you really wanted to see the tiger, how are your pupils looking? They're big. I want to see this thing, right? Pupils really tell you a lot when you're picking somebody up, okay? Dangers of amphetamine, obviously increased heart rate, heart attack, arrhythmias. Increased blood pressure, danger is going to be your stroke. Aggressiveness, psychosis, anorexia if you do it enough. Hyperthermia, you cook your brain, that's not good, okay? And of the drugs you develop tolerance to, these you develop a tolerance to because you release so much of those catecholamines you cannot rebuild them fast enough. So the next time you take the same dose, you just your body couldn't rebuild back up to what it was, and so it was a little less. So you're like, boy, I need to take more. And these are the meds that you'll see people need to take more and more and more and more on a somewhat regular basis, causing more and more increased heart rate, increased chance of heart attack. So once someone's on this, they almost have to take more to even get the same response. Treatments, benzodiazepines are your treatment of choice on this. Agitation, benzodiazepines. Hypertension, benzodiazepines. Okay? Please do not give somebody any kind of beta blocker. You can possibly cause hypertension more so. Tachycardia, benzodiazepines, possibly calcium channel blockers. Avoid beta blockers again. For the exact same thing, you'll get unopposed alpha, and the hypertension you can't do anything about it, just out of control hypertension. Hyperthermia, someone's really hot, benzodiazepines. You notice benzodiazepines all the way through that. Other things as well, IV fluids and stuff like that. Cocaine, how does it work? It blocks the reuptake of epinephrine and norepinephrine, promotes the release of presynaptic norepi, and it blocks reuptake of dopamine and serotonin. That's a slight difference with the amphetamines. The dopaminergic, people feel really good about themselves. Amphetamines, you feel good about yourself, but cocaine, you really feel good about yourself. The downside with cocaine, you're not as focused. Okay? You got a lot of energy, but you can't do a good job. So if you got a coworker who's like really sluggish and then all of a sudden has great energy and the job is kind of crappy, well, it's probably cocaine. If you got a worker who didn't have a lot of energy, they came back and they are so focused, they're lining everything up, probably amphetamines. That's kind of the difference you may see in that. Otherwise, they're really similar. So, everything I talked about with amphetamines, cardiac, all that stuff, same thing with cocaine. Big eyes, you're going to treat it the same way. Benzos, fluids, please don't give them beta blocker. Voila. LSD. LSD is using the same mechanism-ish, that your fight or flight stuff, okay? Mechanism of action, you're going to increase your serotonin levels. This is where you're getting the hallucinations. These effects last 6 to 12 hours. LSD gets a bad rap because everybody who thinks this guy's freaking out crazy. He's on LSD. Most people that are on LSD are sitting in a room going, they're somewhat aware of what reality is, but they're seeing like the elephant or somebody else talk to them. But they still kind of know what reality is. I mean, they're not, most of the time, are not going crazy. So, but everybody knows it's hallucinogenic, and so they just automatically go, it's got to be LSD. Yeah. Most of the time, it's not LSD. And if they thought it was LSD and they're freaking out like that, they probably thought it was LSD and initially started working like LSD, but it probably wasn't LSD. And we'll tell you about those in a little bit. At normal dosage, you get pleasant visions. You can get auditory hallucinations. Not a lot of things give auditory hallucinations. LSD does. So you can hear, see things. An overdose, you'll get a bad trip. Then you're agitated and you're scared. Then it might be LSD, someone freaking out like that. If you get an overdose, they have now bought themselves a free trip sometime in their life. Often it can be with some sort of injury to the head, then they may get the free trip. Okay, so if you got somebody who's overdosed on LSD, anytime in their life, and they're in a car accident and you pick them up, and now they're just ballistically nuts for not much of a reason. They just got a slight boo-boo on their head, Sometimes it's a free trip. Agitation, disorientation, hallucinations, primary visual, auditory, or tactile. It can also cause tactile. Again, that's rare to find in drugs. Most of the time you can't get the auditory or tactile, but LSD does that. Neuromuscular hyperreflexia, and what do your eyes look like? Big. All these, everything on out, big. Okay? PCP. If you got somebody that's going ballistically nuts and like superhuman strength, this is what it is, not LSD. Okay? It affects your alpha adrenergic, which gives you the hypertension. Can also cause that anticholinergic. When we talk about anticholinergic, we talk about people go crazy. They're like nuts. Great. On top of a hallucinogenic, you got, yay, right? And you get it's got some dopaminergic properties. People seem like they're superhuman in nature, like can possibly be shot, not necessarily feel it, and still be coming at an officer. They'll feel it later, but they're just jacked up. I mean, this stuff is like the over the top, because they can be somewhat dissociative in the fact that they're not necessarily feeling everything that's going wrong with them until later. Yeah, but it's even like to a whole nother degree. Like they may break, something that's holding them down, which almost seems superhuman, but they're also probably breaking their arms and other things as well, and they're just not necessarily feeling it. So these are you don't see this abused often. People don't like this, and I'll tell you in a moment why. It comes in 3 phases of the drug. It's this excitatory, then you get sedated. Okay, you get behavioral abnormalities. At low dose, it's near schizophrenic psychosis. Okay, and then as the dose settles in more, then you become somewhat catatonic. So you're just kind of like, and then you go back into that lower phase where you're schizophrenic. Okay, so if you're hanging out with a buddy going, hey, I'm going to get schizophrenically crazy, and then I'm going to be like in a coma, and then I'm going to be schizophrenically crazy. You want to hang out? No, I don't, dude, right? So that's why you don't see this abused as often. But people can get that superhuman stuff, but they don't even remember that superhuman stuff, okay? You get hypertension and tachycardia because it's working the same way as that whole lion chasing you stuff. It's using that same mechanism. Hyperthermia also, same reason. Ketamine. Ketamine is dissociative, similar-ish to PCP, a cousin of PCP, okay? It ramps up the NMDA receptor, so you get a lot of excitability that goes on in your brain, so much so you can actually take your brain like it's somewhere else, and someone doesn't necessarily feel that their leg is, in a completely different direction. Most time, patients don't want to go into what is known on the street lingo as the K-hole. K-hole it's where they become like in a coma. Yeah. They're still breathing. Most time, they don't want that. They want that, excitability, look at, So it's similar to PCP in the fact it has those 3 phases, okay? So that lower phase, where they don't feel some of the pain that's going on with them. They see some great visions, stuff like that, feeling okay about themselves. Definitely lethargic, but, not out. Can be pill, can be injectable, can be topical-ish. Yeah, it takes a lot more to do topical, but yeah, most time it's pill. Sometimes can be passed off as another drug because ketamine is, again, not really abused much, so cheaper. So, you know, those drug dealers, sometimes they might not be as truthful or honest as you like. I know. It seems unheard of. It is. So they may pass off ketamine as ecstasy in tablet form. You may get the same effect like ecstasy, but it is going to be different. So this what you're going to see with this, you're going to see nystagmus, big pupils. The nystagmus on this, though, horizontal, vertical, 1 of 3. The other one that will do it, PCP will do it. Okay, so PCP, ketamine, will give you vertical nystagmus. The other drug that will give you vertical nystagmus is a dextromethorphan overdose. So if somebody is still with it enough to still follow your finger to look, and if they got vertical nystagmus and it seems like they've ingested something, it's probably one of those 3. It's not often that you get them to be able to follow in directions like that, though. Okay, most of the time by the time you pick them up, they're not able to follow the directions. But if they could, or if they can, and you're able to see that, it's not diagnostical as probably one of these 3. There are other biological reasons you would get vertical nystagmus, most of which are not good, as like tumors, other badness in the brain. Okay. Well, let's also do ketamine will also cause hypertension. Also, you can get catatonic with it. Okay. That newer stuff, those newer drugs that are out there, they really come in like 4 subclasses. They're stimulant hallucinogenics, similar to your ketamine and stuff. Okay, your piperazines, you don't see too much of that. Phenylalamines, you'll see the 2C or 2Ds. Those you're seeing. Okay, and the other thing that you're also seeing is there's a 25. I'll pull it up in a moment. There's also in the phenylalamines. Ecstasy is technically a cathinone, which is also in the phenylalamines. Okay, your tryptamines. There's not a lot of abuse currently out there, but it definitely has the capability of. And your piperidines. Hold on a second. I'm going to maybe show something. This is all the drugs that the DEA has down for what they are chemicals of concern. So when you look at piperazines, that's like we talked about your BZP, these tend to not cause that tachycardia, they'll cause a hallucination. Okay, they'll still have the big pupils, not tachycardic, and it's mild. And technically, these are not a controlled substance, just got ruled on. I'm not trying to advertise that. I'm just saying, technically not illegal. Phenylalamines, this is that main class. You're seeing a lot of the 2C and 2D, and they're all kinds of, they put like a bromo, a chloride, and iodine on there, and they get a little bit different affinity. You're going to get tachycardic, you're going to get big pupils. It's going to look like ecstasy-ish, but technically is not. There might not be as off. Ecstasy will make somebody like way off. Okay, they might be somewhat with it, but still getting some of those intense effects, but still able to talk to you and tell you stuff. I'd be more concerned about being a 2C, one of those. Okay. Of this exact same group, 25. These are new in the area. They're known as bombs, or these are also being sold as on blotting papers like LSD. Okay. And people may think they're getting LSD, but they're getting this stuff. And the 25s, which is right here, sorry, you're looking at structure. And I don't have much else on there, but those are very, very potent. You don't need much to put somebody over the edge. It can actually cause death. Well, LSD is fairly, but not, doesn't, yes, you may get tachycardic, all that stuff. I was just telling you, it gets a bad rep. These people may think they're doing LSD, and they may die from it. We've seen a few cases of these as well. And these things it's intense on for them, okay? And they are way out of whack when you see them. And then Simulant, and then way out of whack, like some of the other things we'll talk about. So I'm just letting you know these are things that are new. This is where everything is expanding. And I wish these chemists out there could like use their powers for good. I mean, they're coming up with all these new drugs. Hey, awesome, why don't you cure cancer as well? I mean, if you're doing stuff, but they're able to tweak some of these drugs and make something different. The other thing that's in this group is cat, which is actually a plant you can get. Ecstasy, which is right up there, is in that same group. Your bath salts are also in your phenylalanines. Bath salts were big a few years ago. There are 3 types of bath salts. Your first one was methylone, which was similar to ecstasy and what it would do. Then you had mephiridrone, which would be similar to methamphetamine in how it was working. So they'd be really energized, and slightly hallucinating. That's good to pick up, right? Get somebody who's really energized and hallucinating. Oh, fun, right in, right? And then the other one you get was Indium PV, which is similar to cocaine. So they're really, really energized. And again, hallucinating. So your bath salts were big. A few years ago, they've kind of fallen off, but they're still around. So they're also in that phenylalanine group. That phenylalanine group is the group that keeps expanding. I'm sure the other stuff may expand later. Your tryptamines and the other ones may expand, but they're not currently as big, definitely in this area. And they have a little bit different profile. They don't give as good of a high as those phenylalanines do. So what I'm telling you roughly today, what I loosely showed you today, may be different in like a month from now. Okay, this is where everything is expanding, and it's hard to keep up on because people are out there again making stuff, right? The main one that's in this group is really MDMA, also known as ecstasy. Okay, as you see at the very end of that big long word is amphetamine. It really is an amphetamine. Okay, so it's using that same mechanism, that whole fight or flight. Getting that rapid heart rate and all that stuff. But it gives you a higher release of serotonin, a lot more hallucinations with it. Okay, and the effects last a lot longer, 6 to 24 hours. Okay. Tachycardia, hypertension, big pupils, hyperthermia, and that can be with or without serotonin syndrome. Serotonin syndrome, when someone has serotonin syndrome, they have rigid, like when you move them, they're just very rigid and they're becoming very hot. Okay, if you see someone who chronically uses ecstasy, like say for clubbing purposes, they may get such a locked jaw that they will put a pacifier in their mouth to keep their mouth open to keep drinking fluids because their temperature is going to get hot. And if they keep drinking fluids, it can keep the temperature down. The moment they can't keep drinking fluids, their temperature will rise and they will cook their brain. So patients that may be at rave parties and stuff like that, because it's very intense with the lights and stuff that this will produce for them. And they tend to become sexually inappropriate. So be careful when you're picking them up and taking them in. Treatment for all this stuff. Benzos for some of the psychosis, safe. All around. You're not going to harm them with the benzos, getting them to calm down. Okay. Hyperthermia, fluids. Benzos also help, but fluids if you can. That's why the users are drinking that much water, right? Dextromethorphan is over the counter. It's an over-counter thing. You can just get DM. Robitussin DM you can find, right? Everybody's had it. Most people don't abuse Robitussin DM. I'll tell you in a moment why. But it's a cough suppressant. It's a distant cousin of codeine, so one would think, boy, you'd be like codeine, like an opiate, if you overdose on it. No, it's not. It actually, as it's working, where you can find it, like I said, is Robitussin DM, and most people that abuse it is Corsine and HBP. And why isn't Corsine and HBP behind the counter, I'd like to know. Gosh darn, I need Sudafed. I got to go, well, it's fortified the counter, You know how much Sudafed you need to make methamphetamine? You need a lot. If someone goes, yeah, I need a truck of Sudafed, that's the person that's making meth. I'm getting 12 tablets because I had a cold. I don't think I could get enough meth, you know. But they got Corsine and HPP all out for kids to hallucinate on. It's okay. Nobody's upset about that. Dextromethorphan, how does it work? Hey, at normal dosing, you remember that excitatory, that NMDA is excitatory? It quiets that down. Yay, your nerve is not as excited. Decrease your cough reflex. Toxic dosing, it blocks that excitatory channel open. Now you get nothing but excitatory. It's similar to PCP and ketamine in its results. It's over the counter. Again, why isn't it behind the counter? Hyperexcitability with lethargy is what you'll see. So if you touch them, they will be swinging and all this stuff. And if you don't touch them, they're like, they may just sleep it off. But the moment you have to go in the room, bump them, something, they're swinging at you. They're crazy. Slurred speech, sweating, high blood pressure, big pupils always with all these. If someone is on an antidepressant and they overdose on this, they definitely may have a chance of serotonin syndrome, which means they can get very hyperthermic. Rarely found alone. If it's in a cough syrup, this is why no one really will abuse the cough syrup. And if they do, they only do it once. Because guaifenesin, that's in the DM, is a mucolytic, which means it makes your mucus thin and runny. You have mucus lining your intestines. You make your intestines liquidy and runny, and you're hallucinating. Use your own visual picture. You could probably find that person. They'll leave a trail, right? You know where they went. That's why it's probably only done once if it's done at all. What they tend to do is do the Corsine HPP, which tends as an antihistamine with dextromethorphan. Your antihistamine, if you go way back to your anticholinergics, makes you crazy, right? Tachycardic. And you're taking it with dextromethorphan, which will make you crazy, and tachycardic. So now you've got someone who's going really ballistic. And then they may become somnolent now, and that's great, but when they're up, they're swinging, they're going nuts. Okay? And the biggest pupils you'll ever see in your life, kind of thing. You can almost feel like you could look at their brain. You're like, I don't even need a light. I can see your retina right now, man. You know? So, it's the other agents with dextromethorphan that really is going to be like the toxic part. The antihistamines we talked about. Obviously, if they did it with Tylenol, ooh, bad move. Great, you are hallucinating. Granted, you're not as crazy because you're not the anticholinergic, but you're getting liver damage, which will affect you in 96 hours. And if they do the decongestant, you got hypertension on top of the decongestant hypertension. So a good chance of stroking out. That is all the toxic stuff that I know of, for the most part, besides some obvious toxic stuff.